this is an annual meeting, right? So I've been with the CONy as one of the chairs for the stroke meeting for over 10 years now. So we have to recycle. We want to make sure that we don't repeat the same questions again and again. So we spread them out over 2 to 3 years' time. So lots of controversies. We end up picking up the ones that we believe are most relevant at the present time. And we usually divide the presentations. Well, there are supposed to be 8 debates if you're in person. There's 6 because it's virtual this year. And we divide them between stroke prevention, acute stroke management, and then rehab and recovery. So if you look at stroke prevention, the 2 areas that we picked for this year are both technology-based. And so the first one is on whether ultrasound, which is very non-invasive, is sufficient to look at the state of the arteries in the neck. And these could be done repeatedly. The technology has been around for 50 years, versus newer techniques that are called CT angiogram or an MR angiogram. So one of the first debates is going to be, is Doppler sufficient, or should we be abandoning the Doppler and going for more of these newer techniques that are, they're more expensive, they have radiation exposure, for instance, and all that. So it's a very good question to debate. The second question on prevention is that patients who have a stroke, a certain percentage, from 20 to 30%, may have an irregular heart, a condition called atrial fibrillation. So to identify atrial fibrillation, we know, and this has been known we were part of some research more than a decade ago, that the longer you monitor the heart, the more you pick up atrial fibrillation. For example, if you monitor it for 24 hours, you pick up about 2 to 4% of patients who have atrial fibrillation. But if you monitor the heart for a month, that number goes up to 16%. Again, the debate is going to focus on that should we routinely do prolonged cardiac monitoring, which comes with a cost. So those are the 2 of our debates we picked up for prevention. In our acute stroke, the TNK versus active place is one debate. Our other debate is on patients with brain hemorrhage. So one of the big controversies that's been going on for at least the last 2 or 3 decades, and just we don't have an answer, is should we manage a brain hemorrhage symptomatically, so watch the patient comfort levels and all that, or because it's a fluid that's pushing the normal brain out, should we take the fluid out, so take the blood out? And over the years, the ability to take the blood out is getting better and better. So what currently is an area that we feel holds promise is what we call minimally invasive procedure. So you put a little catheter down into the bleed and put it out. Now, it doesn't cause damage, taking the whole flap off and going into the brain. But the question is it better than just watching? So that's an important debate. But to see, so the 2 debaters would look at, yes, the patient should have a hematoma removed or not. I'm just trying to see if I can make sure that I don't miss anything. So we've got another important talk in the acute phase, which is new, and I think it's going to generate a lot of interest. It is around the ethics of management. We all as physicians feel that every patient that comes in, we're going to give everything possible for treatment. But that may not be the right approach. There are some patients with a big stroke where the prognosis is bad. And the question is, should we make them, so should we sustain them and make them go through the acute phase, but then they're left with extreme disability, they can't leave the hospital? Is that ethically the right thing to do or not? So it's a very important question. So we've had two excellent experts in the field who would debate when to stop in patients, or should we stop at all? So those are the acute stroke issues that we are discussing. And finally, on the rehab side, another really interesting area, a lot of controversy, but a lot of interest also, is that if you stimulate the brain, so stimulation, does that improve recovery after stroke or not? So that'll be our final presentation for the day.